Thanks, Anne-Marie. Good afternoon, everyone. I'm going to start by sharing my screen. Here we go. Right, so I just want to give you a quick overview of what we did as part of our IV to oral program now quite a few years ago, and why it worked initially, and also how it was sustained past that initial implementation as well. And my slides are going to be quite detailed because I was hoping that people will be able to understand this story even without me necessarily presenting it. So I'll start with the background of why we started this project. The Royal Brisbane and Women's Hospital ranked highest in Australia for 2 years running for highest rates of bloodstream infections, or BSIs, as you know, and not something that anyone want to lead the country by. And what we found also was that audits were showing, particularly this one audit showed that 98% of patients who were reviewed who had IV lines in place were also on oral medications as well. That's not to say that it would have been appropriate for all of those patients to not have IV access, but certainly highlights that there's a lot of patients who it might be a suitable option. Whether these patients were having concomitant IV and oral medications at the time, or whether they had IV lines for other reasons other than medications, wasn't really part of the assessment of that audit and obvious limitations of it. Other audits also found that we weren't very good at removing it even when it wasn't being used, and we didn't require it for any longer. So even if we had a sort of practice in place where we were doing that early conversion from IV to oral, the lines were still staying in people and they weren't being removed. So the patient wasn't necessarily getting the benefit from that early stage. So what I was tasked with was to implement an IV to oral program across our facility. We have 5 service lines. So I only targeted 2 of them just because I wanted to make sure that what we were implementing was actually achieving the outcomes that we were hoping it would, and also that it was going to be sustainable. So the 2 areas that were first this program was implemented was with medicine and surgery. We started with extensive stakeholder engagement. So doctors, nurses, pharmacists of all levels were asked, do you think there's a problem, and what do you think we could do to address? And all those suggestions were pulled to come up with some strategies. We also supported this with quick cycle PDSA, so Plan, Do, Study, Act, to find out when we made a change, whether that change actually resulted in a change, and whether the problems that people perceived were actual problems or more perceptions of practice. We also did the quick cycle PDSAs as a really good way for educational purposes to highlight the importance of the program, and also it really encourages people to motivates people to keep moving forward, having that sort of feedback loop as well. And we also use them to explore potential solutions. So we used internal champions and early on I identified that in the 2 areas the internal champions would be different. So in surgery, it was the nurse unit managers and the nursing leadership, because obviously the surgeons are in theatre most of the time, and the people who really take charge or lead charge are the nurses in a surgical setting. In a medicine setting, it was the medical consultants and the pharmacists. How did I come up with that? It was really through that stakeholder engagement and the interviews. It's sometimes reading between the lines sometimes it's people directly telling me, look, you need to talk to the doctors, or it's the nurses who need to be in charge. as I said before, audit and feedback were undertaken. In each of the areas, then the audits and feedback were undertaken by those internal champions with participation and facilitation from me. So in surgery, it was the nurses, and in medicine, we had a clinical pharmacology registrar and myself, and then we used a medical consultant to provide the feedback. So the intervention was a multidisciplinary educational intervention. There was so much we did over that time. Things like promotion of switch from IV to oral oral at the earliest opportunity, leveraging of antimicrobial stewardship program to really highlight, that opportunity for early conversion. Obviously, there are a number of medicines that fall outside the antimicrobial space that can also be converted early from IV to oral. Use the pharmacist in that space to make sure, we use annotations in the drug chart to say, we suggest that you could swap this over from IV to oral or during ward rounds. We also promoted, so on one aspect of it was really talking about that IV to oral conversion. The other aspect was around promoting the early removal of the vascular access device if there was no need for it, including no IV medications being prescribed. But so, for example, if a patient was waiting to go to the theatre, they may not be getting any IV medications, but they do need that access. Then there was another cohort of patients who were very difficult to access. So they would then deem to leave that line in because of deteriorating conditions, etc. So there were caveats where people were allowed to have lines in situ, but this was more around being actively reviewing the ongoing need for and making those reviews more regular and then removing when not necessary. There was also promotion of actively reviewing the need for IV medications at the bedside. So it's not vilifying IV medications because obviously we need them and it is completely justified to use them. It was more around reviewing them and having active reviews. We also developed a quality improvement framework to incorporate this ongoing audit and feedback and education that was driven by those internal champions within the two areas. And then I made sure that it was underpinned by implementation science methodology, particularly CIFA, which I'm a big fan of. So in terms of evaluation, sustainability, and so we started this work in late 2014, and then what happened through 2016 and onwards. So past me directly having a hands-on approach to the project, each surgical ward sort of committed to doing 2 audits per month themselves. They collected things like number of patients with IV cannulas in situ, number of patients who are using the cannula and the reason, and then patients who are identified during the audits who are eligible. It says edible there, eligible for an IV to oral switch would then be highlighted and they would act on that during the audits. The audits were undertaken by the nurses on this ward, and every month they would submit it. So this is a comparison of a snapshot from one ward. So if you look at the first column going down, that's pre-intervention. So that's March in 2015, a whole month, and we had 20 patients on this ward. And post-intervention, so the intervention was me as a project officer, plus all the other things I described earlier. We actually reduced number of days with the cannula in situ from 88 to 44 in this patient group. We also decreased the mean days with the cannula in situ from 4.4 to 2.2, so early conversion from IV to oral. And then number of days of cannulation without IV meds. Remember I said that people would sometimes be left with their cannulas in place without it actually being used, reduced from 23 to 14, and mean days of cannulation without IV meds also reduced from 1.15 to 0.7. So that was really promising results and really energized this program, gave it a real good boost back then. And then from 2015 onwards, I was really looking to give this back to the service lines, move away from me being the central person who was driving this project to getting that ownership from each area, because otherwise the sustainability of the program will be really challenged. So I did that gradually, stepping back each time a little bit, and then putting that framework where they did their own audits and acted on them and used that as part of their education loop. So this follow-up we did in 2019, almost the same period. So in February, we still recruited 20 patients, and number of days with the cannula in situ was 70 at that time, but mean number of days with cannula was 3.4. Number of days of cannulation with IV meds had actually decreased even further to when the project was originally in place to 11, which is fantastic. And so, what it really means is that they were quicker to review the patient and quicker to remove the cannula if it wasn't being used. In terms of looking at use of IV medications pre and post implementation and follow-up evaluation, again comparing those three periods, number of days of IV medications went from 63 to 30 to then to 45 in the longer term, which is still an improvement from that baseline. So it was indicating that we were having a very good and a sustainable IV to oral switch program in place. Again, mean number of days of IV medications was reduced. Total number of IV doses administered was dramatically reduced, and average number of IV meds administered was also decreased from 11 in the pre-intervention to 3.45 in the follow-up. What a good result. We did a cost analysis as well around, we showed a reduction in antibiotic use, pain medication use, antiemetics and fluids being the big items that we find people are on. So I guess if we were to look at a little bit more in detail of the program, the results of the 2019 really demonstrate that this program has been successfully integrated into our standard clinical practice. Day to day, I have very little to do with this now, even though I still sort of remain the go-to person to inquire about the program, etc. And we've put in some changes to the way we do things. For example, there's a daily review now of need for a device by a medical or nursing or pharmacy staff. We encourage de-escalation of treatment through either early switch from IV to oral or SEES. So that's the other important message to get through. It's not just simply converting from IV to oral, it might be IV to SEES as well. We use regular audit and feedback at a ward level, and it's always led by nursing staff and supported by pharmacy. Regular discussion and progress around the nursing leadership has really helped as well. In terms of intervention and resources, the coordinated audit and feedback, I would say that together with really understanding the context is what's really helped this program, and also sort of having a vision of how do we integrate this into business as usual if we want to really make sure that sustainability occurs. We tried all sorts of things. So we had back then we had things like educational PowerPoints that people could watch, vascular access device stickers that were put on that triggered people to review. We made some changes to something called the daily patient care record, which was asking that question I said before around, what is the need for this vascular access? One of the things that was highlighted was that we need to have some guidelines around antibiotic prophylaxis. So we got that developed, and the program was also sort of integrated the antimicrobial stewardship teams as well as the acute pain services, because both pain management and antimicrobials are two of the reasons that people might be on IV medications as well. So going on to, I'm just keeping an eye on the time as well. I'm just going to move this. Going on to what lessons did I learn? Well, one of the first things was to really not to assume that everyone is keeping front and center that patients do require IV lines, patients do require IV medicines. And so instead of vilifying it, it's more around regular review for the ongoing need rather than saying people don't need IV. Sometimes we measure the wrong things. So making sure that we are measuring the right things. Just because someone's on IV medicines does not necessarily mean it's inappropriate. It is inappropriate only if that patient no longer requires it. So it's having those conversations and making sure that when you're running campaigns that you highlight the bit to focus on is, does the patient need ongoing? Is there a need for ongoing treatment rather than is there a need for IV medications, etc. Program really, for that reason, program was really careful to promote regular reviews of IV medications rather than calling them inappropriate. Important also to clarify and clearly identify who's the most influential people or persons responsible for patients in the context of facilitating the IV to oral switch. So going back to medicine and surgery, in medicine it was just nurses asking the question, and in surgery it was the doctors sort of leading that charge, if you like. And that brings me to the end of my PowerPoint.
Some great results there, Champs, with the sustainability 4 years on.
Yes. I'm so proud of that program.
Yeah.
It's really nice to be able to implement something and then see it flourish in the absence of you rather than because you're still dragging everyone along.
Yeah, definitely. It doesn't look like there's any questions so far. We do have people online. I guess one thing, hang on, Kim James, this is amazing, thank you. Was nursing time investigated at all?
So nursing time to do this work, is that what your question is? If that was a question, then it didn't take, well, I'll be lying to say it didn't take any extra time, because any task that you add on to regular task will take some time. But I was really, really focused and dedicated to making sure it didn't take a lot of time. So I wouldn't really ask people to do anything over sort of 30 seconds to a minute more than what they already do anyway. So we used processes that were already in place just to ask this one extra question. We didn't do any additional data collection that couldn't be done within 30 seconds. Any reporting was done with like minimal time investment, because if you didn't do that, you would then have to identify something they didn't do in allowing people to do this. And some of the awards were so good. They ran their own little competitions and posters and educational sessions. They really got behind it. So yes, the short answer to it is yes, it did take some time, but it didn't take more than up to a minute extra.
Mm-hmm. I guess on the flip side, before we get to the other questions, did you look at nursing time saved from, I guess, no?
No.
Okay. All right, so thanks, Kim, for your question. Charmaine from WA, great detailed talk, thank you. What systems or methods did you put in place to ensure IV was reviewed and not dependent on people's memories to review?
So the most significant integration was changing the patient review form, because it kind of in some ways hardwires that review to happen. But then because it came after a lot of promotion and engagement for staff, they were more likely to do it rather than if we just went and changed the form and added another line, because quite often people don't even know it exists, don't really see the value in it. So we actually spent a good year and a bit really getting the staff to understand the value of this before we made sort of those hardwired kind of changes. So that's the first thing. The other thing was the surgical service line as a service line really came on board to this idea of quality improvement, because they could really see that this worked and it was their hard work, and they all really owned it. It was such a lovely thing too, where so we have quite a large surgical service. I think we have, off the top of my head, about 250 surgical beds, so quite a big service line. It was a collective win. It wasn't one person. It wasn't, yeah.
Great, thanks, Chance. So from Satira, aside from the audit and feedback mechanism, how did you promote the activities across the service? Great work, Champs.
Just audit and feedback, education, a lot of establishing a lot of personal relationships. So the first couple of years I would be on the ward helping, doing the audits and the education. I was present. There was a lot of people know me because I spent quite a lot of my time there. I was always available to help out. And then it was, when I was stepping out, it was a gradual step back and integrating it into the existing program. So that was, I guess, that was the kind of the way that we did it. So I think it was Kim who asked me earlier on, did it take any extra time? Because there was a lot of upfront investment. And by the time it came to 100% being driven by the service line, it didn't take a lot of time. But if we had gone in first, done it for 3 months and started stepping back, I guess that might have resulted in taking more of those nursing time as well.
Yeah, that makes sense. Thanks, Satira. Then we've got a question from Melinda. Do you think this was so successful because there was already a culture of quality improvement? Very impressive results.
Thank you. I can't really comment on it because I can't, I don't know, but yes, maybe, but it is also, I have to say, a very lovely area to work with, very open for pretty much anything that I go along and say, hey, we're doing this now, and they're quite game to do it. And I do feel that there aren't many people who would voice their reluctance to participate in audits and feedback and quality improvement. Having said that, I'm also really, really mindful that I don't take anyone's time or resources, and I really make sure I get that buy-in before we go ahead. So it's hard to know what comes first, but it is one of my favorite areas to do quality improvement.
Another question here from Janine. Were you dedicated to this project, or did you do this as part of your existing role?
No, I did it as a part of my existing role. So at the same time, I was also doing anticoagulation, improvement around anticoagulation, starting up the opioid stewardship work. I have only 0.8 FTE as a whole. So I was doing multiple things as well.
Thanks, Chaps. Sounds like you had a lot on your plate. I think that's it for questions. I guess the other thing that we've been talking about is Royal Brizzy Hospital is probably one of our more established Choosing Wisely hospitals. They've been involved with Choosing Wisely from, I think, the first year, really.
Yeah.
Can you give us a bit of a breakdown as to how you've sustained Choosing Wisely so successfully?
So I think part of it is we've kind of been on this improvement journey for quite a long time. So I'm the quality use of medicines pharmacist for the Royal, and I don't know whether a lot of hospitals actually have a dedicated resource just looking at improvement, even in medicine. Albeit I'm only 0.8 of an FTE. I've been there for now, I think, 13 years in that role. So it's a long time. And then we have medication safety officers, we have safety and quality officers. So there's a lot of improvement, people who might have improvement in their portfolio present in our system. So because we already have sort of an improvement, what Choosing Wisely brought in was a way for us to really bring all improvement under one banner and recognize what we do, and then also identify new areas that we could improve, etc. So when we first became a Choosing Wisely facility, I can't remember when, I should know this, but I can't remember when. I think maybe 2018, 2017, I'm going to take a punt. There was a lot of excitement, but the biggest thing Choosing Wisely brought to us was really we're also a really large organization. So we have, I think, 980 beds, a huge hospital. So it just brought everything to focus about all the good things we're all doing, and then sharing different ways of doing and addressing problems. And I think when Jessica Tolman was our Choosing Wisely champion, one of the things she did was bring in a framework for at an executive level for us to really report back on. So our exec at their monthly meetings report back on their quality improvement / Choosing Wisely programs that they have in place. So that then promotes that ongoing focus on improvement. And I think we've got to a point now where it's just something we do. We don't necessarily have to, different areas do need focus and excitement and encouragement, but we don't as a whole necessarily need to sort of celebrate that as much as we did back then, because this has become a bit of BAU, if you like choosing, change, and Choosing Wisely has been implemented. So, for that reason, I think it's a culture change, and it's time, and it's also different people of influence being around to implement change and promote change as well.
Right, thanks, Champs. So I think it's a really good example of where you had designated project funding for, I think it was 1 year.
1 year,
yeah. And then it was integrated into processes. So Champs has kindly offered to help write up something like some tips for the health services in the same boat as well. Yeah. So we'll let you know when that's ready.
I think for those of you in the audience who don't know what I'm doing at the moment, so I'm implementing opioid stewardship across Queensland. So I'm the clinical lead for our opioid stewardship program. One of the things that I've really wrestled with is how much the tension between having just enough dedicated services and resources and having too much for too long as well, because you need people to have that ownership and understand it is their responsibility. It should be part of everyone's job description to do quality improvement. It's not, some one person's responsibility to carry that for a whole facility as well. So I think I bring that because at the moment I'm the clinical lead for Choosing Wisely at the Royal, which is not at all a dedicated resource in any shape, manner or form. But it's and it's good because we'll increase that if the need arises, but at the same time, because there's no need at the moment, it's good to keep the status quo. I don't know whether I'm making my point very clearly.
It makes sense. Yeah. Okay, great. Thanks for such a good presentation, and thank you everyone for attending. We'll see you next month. On the first Thursday. I think we have Matt Anstie presenting on blood cultures at Sir Charles Gardner Hospital in WA. Thanks again, Champs.
Thank you. See you later.